point to them. And that's why the index of suspicion should be high. And that's a diagnosis that can go undetected. The person goes on an antidepressant and they become manic, or it's easy, especially with alcoholics who've got chaotic lives, it's easy to not see it's masked. You know, the periods of hypersexuality and spending and everything could be, let's go to Las Vegas. And, you know, and the person's also a gambling addict. And they're also another addict. They also have another addiction. So it's easy to not see the manic component to it, except to the trained clinical eye, which we have here at the foundation, thank God. So, and now you have it today as a result of this training. So I think that's one of the goals and objectives for today. Participant will have a trained clinical eye as a result of completion of this, what is this called, grand rounds. What's the difference between rounds and grand rounds? I remember going on rounds with the doctor, you go around the table, they take the thing, but why do they call it grand rounds?
Because you were the speaker.
Ain't it grand? Thank you. Thank you very much. Psychotic disorders. We don't see a lot of psychotic, I'm sorry? Oh yeah, thanks. Cognitive impairment. You know, it's more prevalent than you think. We have a doctor here to help me out. There's some new medicines coming out now for people with Alzheimer's. And I want to get my hands on those. No, I'm really kidding. Relatively uncommon. It's relatively uncommon to see we don't have actively floridly psychotic patients here. Staff is another it's part of our exclusionary criteria. But what I do see is a lot of sort of atypical psychotic symptoms, what I call psychic fragmentation, disorganization. I see it a lot with hyperexcitability, so a lot with young adults, but they have periods where they lose it. They may be brief, and they can be delusional, temporarily delusional, and it's crazy behavior. And can be drug-induced or not drug-induced, or kind of goes along with a drug-abusing lifestyle. So that's where some of the newer atypical antipsychotics seem to be really useful medicines to seal somebody over, glue them together, and keep them together, and they can take advantage of treatment here. So, most of these patients almost always have a personality disorder also. And that always complicates treatment. When somebody's got a personality disorder, it makes the management of the Axis 1 disorder, the depression or anxiety, whatever it is, harder because treatment compliance, the patient is resisting, they're throwing up walls of irrelevancies and other defenses that can block the effective treatment of. It's hard to say, hey, I want to treat you, but you're not working with me. Work with me here. Just be on the same page together. That's where the therapeutic alliance comes in. I'm going to skip the little data here on schizophrenia. You don't see a lot of it. Cognitive disorders. When you look at neuropsychological test data, 4 out of 5 patients who first come into treatment would have a neurocognitive disorder, transient and directly related to addictions. Again, after a week to 10 days of abstinence, a lot of the cognitive clouding, problem solving, learning problems that can go along with addiction start to subside. And I don't really see, I can count maybe on both of my hands the amount of times I've seen where he's encephalopathy or Korsakoff syndrome, like severe alcoholic dementia, in a place like Cairn. A lot of the neurocognitive damage is recoverable from addiction, up to 80%, up to a year. That's kind of the rule of thumb. So people start looking good. And as long as they stay away from alcohol particularly, but other drugs too. So it's for the most part resolvable or resolvable enough. And there's always the brightness factor. If you start out with an IQ 160 and you drink yourself into oblivion over 30 years, now your IQ's down to about 120. That's still pretty good. So people can look. We have a patient here right now who's very impaired, long-term, happens to be an attorney, and but The guy still has a lot of brain power, even though he's not functioning where he could be or should be. But because he's got a lot going for him, the dementia associated with it, cognitive loss associated with addiction, is less obvious. Somebody with an IQ of 90 can't afford that. And that's when we get this concept of social drift. The people who are, in sort of borderline intelligence ranges, and they start suffering cognitive damage, they start slipping down into, they can't hold a job anymore, and then they see, they're sleeping on the streets, or they're in a permanent dependent type position because they didn't start out with a lot to begin with. Now, there's some recent research showing the neurotoxic effects of methamphetamine, very bad for the brain. Almost makes brain cells explode. And there's a lot of studies showing neuronal death. And so after alcohol, it seems to me that's the most serious damage. I mean, inhalant abuse has always been, but I don't know, do you see much inhalant abuse on this side of the street? I don't really see it. It's usually an addiction of young people who can't get a hold of the Jack Daniels yet, or the drugs yet, because they don't have the resources yet. I'm going to fast forward to this next section here, which is on the differential effects of alcohol and drugs, what they do. One way to look at alcohol and drug use, in addition to seeing it as an addiction, is to see it as an ego prosthesis. That some patients drift to certain drugs. There's a rhyme and reason to it because it kind of fills in some of the gaps in their ego function. Most consistent finding in terms of ego functioning with addicts is a deficiency in self-care, which is something that we assume with normal people, is that they know how to take care of themselves. But that's not always true. In fact, it's glaringly obvious that a lot of our patients don't have that. It's like a car without a carburetor. It's not going to run. It's a vital function that the ego should have to take care of itself, and it's often impaired, or it's often blocked by codependent behavior in our orientation, where the person is literally self-sacrificing and dying and taking care of everybody else around them. Now, treatment guidelines. Sequential treatment, parallel treatment, and integrated treatment. According to the Congressional Report on MESA, integrated treatment is the most effective way to go with this population. That is, mental health problems and addiction should be seen as interrelated problems and should get its diagnostic and treatment attention. Some programs, I think Hazelden used to be this way, I'm not sure if they are anymore. If you have a mental health problem, that's not discussed in addiction treatment. You go to the mental health place. And it's a parallel process. And there's, I don't know, does anybody know if that's still true or has worked at Hazelden or know anything about I haven't met their staff members in a long while. But I think that there are some places that espouse that treatment philosophy. The other is sequential. You treat the mental health problem first, then you treat the addiction. Or you treat the addiction first, then you treat the mental health problem. The treatment of choice, or the model of choice, is integrated treatment. Which I think we kind of do here, don't we? We tend to, we may not spend a lot of time on the mental health issue, but it certainly is identified and seen as important for continuing care. There's some attention to it paid here. Next is a suggested treatment approach, which is pretty self-explanatory when you get somebody with a dual diagnosis problem. So I'm not going to spend a lot of time on that. Okay, psychopharmacology. There's a lot of that going around these days. And the wonderful thing is, even though medicines get a bad rap, the wonderful thing is more and more medicines that can take a lot of the human misery out of life, the mental misery that people go through. And most of them, or a good number of them now, are non-addictive, so they're appropriate for our patients. So even though there are critics who say, there's too many people are over-medicated, people are taking too many medicines, that has to be counterbalanced with, yeah, but these medicines are getting more and more specific in their effects, more targeting symptoms better, or tolerated better. So for somebody who's